So let's start with dysglycemia, so blood sugar stability. So here's a rule. You cannot normalize a mood disorder if there's a blood sugar instability pattern. It is going to be a nightmare. And you're going to see for the rest of your career, patient after patient coming in from other practitioners that have been working with mood disorders forever. They've done all types of different protocols, and they just didn't really put enough attention on getting the patient's blood sugar stable. And then that one intervention that you do is going to make the biggest difference in turning them around the corner, right? Do not overlook this. This is absolutely a must, okay? So when we say proper blood sugar function, we mean they're not in a hyperglycemia state. In a hypoglycemia state, they're just kind of stable throughout the day. Obviously, they have some ups and downs, but it's not significant. With hypoglycemics, we get this really drop in blood sugar, which then causes an insulin surge, and then we can get even a hyperglycemic event and stuff, but it's just like roller coaster ride. With insulin resistance, we have high amounts of insulin circulating, which create their own problems, which we'll go over. And then sometimes these huge insulin surges causes hypoglycemia and intense sugar cravings and need to eat food, and then boom, you get back to insulin resistance, and these insulin surges cause fatigue. Now, the profile of a patient that has hypoglycemia is like right here when they start getting low blood sugar. That's when they get shaky, lightheaded, irritable, hangry. This is when their brain function goes down. This is when their brain endurance is involved. And they eat, and they can function a little bit better. But this area where they have their blood sugar levels drop, and then up to back to normal, is already going to disrupt many neurochemical pathways. So every time this happens, we're getting neurochemical disruption. And just the fact that someone has high insulin resistance or has hyperglycemia or insulin resistance patterns throughout the day, this hyperglycemia pattern is going to cause chronic inflammation, oxidative stress, and these insulin surges that take place when these blood sugar levels start to spike up are going to have severe dysfunction in neurochemistry. So the summary is like variations in the blood sugar levels, these big significant ones, are going to cause neurochemical alterations. So let me start with each of the neurotransmitters. And we touched upon this a little bit yesterday when we went over the neurochemistry of neurotransmitter pathways. So if you look at serotonin synthesis, and it's happening all the time, this area right here that's boxed in is such a critical mechanism that allows constant, efficient serotonin synthesis to take place within the neurons. So in order for serotonin production to take place, we need precursors like tryptophan to get into brain, to get into neurons. They have to cross the blood-brain barrier. And this happens from protein consumption, but eventually the proteins get converted down to individual amino acids and then to branched-chain amino acids. And the ratio between branched-chain amino acids and insulin properly activates large neutral amino acid transporter, which is the carrier that tryptophan has to bind to in order to cross the blood-brain barrier. Meaning tryptophan cannot cross the blood-brain barrier, and that's bound to large neutral amino acid transporter. A large neutral amino acid transporter is not going to efficiently work when there's abnormal insulin surges or fluctuations of blood sugar levels like this. These change the ratios between branched-chain amino acids and insulin, and this disruption then leads to inefficiency for tryptophan to cross the blood-brain barrier and provide the precursor that all these different cells need to synthesize serotonin. The same exact mechanism happens with dopamine. So in order for neurons to make dopamine, they need the precursor tyrosine, but the tyrosine has to be able to cross the blood-brain barrier to get into the brain. And tyrosine has to be, N-acetyltyrosine has to be bound to large neutral amino acid transporter. And once again, the ratio between insulin and branched-chain amino acids is critical for this to happen. So when there's hypoglycemic events or insulin resistance events, the ratios between insulin and branched-chain amino acids are not efficient, so you get inefficient transport of these precursors into the brain for dopamine synthesis. And when you look at catecholamines, like epinephrine, norepinephrine, it's the same thing. They're precursor pathways exactly like dopamine, and then dopamine gets converted to norepinephrine and epinephrine. So you can see that dysglycemia patterns are so critical there. And then eventually when you look at acetylcholine synthesis here, you can see choline can easily cross the blood-brain barrier. So dietary choline is a phospholipid. Doesn't need a transfer protein to cross. But the acetyl group that's necessary for combining choline with acetyl to make acetylcholine is totally dependent upon acetyl groups coming from our blood sugar metabolism through different citric acid cycle bioenergetic pathways. So once again, you can have blood sugar disorders impact acetylcholine efficiency and synthesis. And then when you look at GABA synthesis and glutamate synthesis, it's totally dependent upon healthy citric acid cycle function. In order for GABA to be synthesized, glucose has to, first of all, get into the cell. So if you're insulin resistant, if a person's insulin resistant, they're not going to get a glucose to be able to transport into the cell very well. If they're hypoglycemic, they just don't have enough glucose to supply the cell. And then glucose will eventually get more converted within the cell, eventually to pyruvate and acetyl-CoA and go through the citric acid cycle. And as it goes through the citric acid cycle, it synthesizes alpha-ketoglutarate, which then can either be glutamate or be converted to GABA. And this is called the GABA shunt. This is the GABA shunt pathway. But this entire GABA shunt pathway to make GABA or even to make glutamate is totally dependent upon neurons being able to have glucose get into the cells themselves. And the brain itself can develop insulin resistance. The brain itself obviously has expressions of hypoglycemia. When people get shaky, lightheaded, irritable, that's when the brain doesn't have enough glucose. So you can see that this whole glutamate GABA synthesis model is totally impacted when there's a dysglycemia. So right off the bat, as we go into how important blood sugars are, when you have people tell you that they get shaky, lightheaded, irritable, they get hangry, or they eat a meal and they pass out, these are all signs of physiological mechanisms that are going to disrupt that branched chain amino acid insulin ratio. That's then going to disrupt large neutral amino acid transporters. Then you have neurotransmitter inefficiency that's happening all throughout the place. So a lot of times when you see people that have symptoms of low serotonin or low dopamine or low GABA or maybe all the above, you have to sometimes just fix their blood sugar issue if it's clear that in their history that they have one, and then see what happens to those neurochemical symptoms. To just go in there and start to give everyone like N-acetyltyrosine, or to give people different botanicals like passion flower or valerian or L-theanine just to support the neurotransmitters without trying to make their blood sugar system efficient would be an inefficient way to practice. So right off the bat, that's the first part I really want to discuss, how dysglycemia patterns totally disrupt neurochemistry. Now the other key thing is that glucose or ketones, but glucose or ketones, they're necessary to make ATP for mitochondria. And the microglia and neurons and astrocytes and oligodendrocytes all need ATP to function. So it's pretty clear that brain function goes down when blood sugar levels are low. And what's very clear is that brain function levels also are disrupted when there's insulin surges and inflammatory responses. So with insulin resistance, it's just difficult to get glucose into the brain. Those receptor sites are not responding. With hypoglycemia, it's difficult to get glucose into the brain. So if the neurons don't have that constant fuel demand met with proper blood sugar stability, there's going to be some ongoing difficulties and ongoing problems. Now here you have an illustration of people have a person, let's say, has metabolic syndrome. So metabolic syndrome being a pre-diabetes state. This can also be the mechanisms that happen in diabetes. But you can see when there's insulin surges that take place, there's also stress responses that are activated, insulin surges that activate adipocytes, fat cells, that creates inflammatory responses. Those inflammatory responses, as we talked about yesterday, can impact mood disorders. These insulin pathways can cause glycation and cause tight junction breakdowns. You get leaky gut, dysbiosis. They can disrupt male hormone and female hormone metabolism. Insulin surges in females will activate 1720 lyase, increase testosterone. Elevated testosterone is going to totally disrupt neurochemical function of serotonin and dopamine. Insulin surges in males are going to increase estrogen. There's going to be some impact on sensitizing serotonin receptors and dysregulating dopamine receptors. All these things impact mood disorders. So you can see how significant metabolic syndrome vicious cycles are to neurophysiology. And then here we have another illustration of insulin resistance. And insulin resistance, for example, glucose above 115, biggest symptom being fatigue after meals, is going to really impact mitochondrial function. So there'll be decreased glucose uptake in the cells. There's less acetyl-CoA for the mitochondria, so the mitochondria are not functioning, which means brain cells are not functioning. That can definitely cause mood disorders and brain fatigue and even promote neurodegeneration. And then insulin resistance is going to promote inflammatory reactions, reactive oxygen species. That's going to make mitochondria oxidative phosphorylation pathways inefficient. It's also going to reduce mitochondrial biogenesis. And chronic insulin resistance is going to just change the cellular function of limbic circuits where these mood disorders become much more prominent. Now, then you get into the main symptoms that you need to be aware of. And this is a diagram that we've used through several different Kharrazian courses. But it's really important to understand what a person's blood sugar stability symptoms are throughout the day. So the best question to clinically ask is, how do you feel after you eat? This is a common question we ask. And the ideal response is no fatigue or change of energy after meals. That's normal. If a person feels energy after meals, you suspect hypoglycemia. If they get tired after meals, you suspect insulin resistance. And these are the other symptoms that typically occur with normal hypoglycemia and insulin resistance. When people have normal glucose responses, they wake up with energy, they feel rested, they wake up with an appetite, they have hunger between meals, but no sugar cravings, no change in function between meals. For those that are hypoglycemic, they wake up with difficulty, they really can't get out of bed, usually their cortisol awakening responses are not functioning well, they have to have caffeine or sugar to get going, they lose function between meals. When they eat, they actually can function again, they crash usually around 3 or 5, they crave sugar, salt, caffeine, typically staying asleep throughout the night, they get nocturnal hypoglycemia, and this alone is going to cause a mood disorder over time. So this is important. And people have insulin resistance. They wake up not feeling rested, recovered, maybe even feeling pain, swollen, inflamed from the insulin resistance. Wake up with sugar cravings, really crave sugar, something sweet in the morning, sugar cravings all day, fatigue after meals, crash after lunch, need stimulants after meals, difficulty falling asleep. So these types of insulin resistance patterns are going to absolutely disrupt normal neurochemistry. So here you have a slide that kind of summarizes the key concepts that I've just been going over. So you see insulin resistance or hypoglycemia. There's actually always a little bit of hypoglycemia with insulin resistance. There's always a little bit of insulin resistance with hypoglycemia because there's a little bit of a roller coaster ride, okay? Now, these dysglycemia patterns are going to cause insulin and glucose spikes and fluctuations. And this is going to, first of all, make acetyl group delivery for acetylcholine synthesis impaired. This can also cause disruption of large neutral amino acid transporter, which will impact dopamine, serotonin, epinephrine, norepinephrine synthesis. So this is where we see in green all the neurochemical disruptions. And then when people have dysglycemia, whether it's hypoglycemia or insulin resistance, there's less available glucose for neurons, which means there's less neuron presynaptic function, less neuron uptake function, less neuron postsynaptic function, and these lead to inefficient neurochemical signalings. The decreased glucose for neurons also leads to decreased precursors for citric acid cycle alpha-ketoglutarate production, and that can impact GABA and glutamate cycling, but it also, lack of precursors impacts ATP for neurons and microglia. And then decreased glucose in neurons impacts the fuel source astroglial cells astrocytes need. Astrocytes are critical for maintaining the blood-brain barrier, and they're also critical for that GABA glutamate cycling within the synaptic cleft. And insulin surges, you can see here, showing it causes inflammation. That promotes blood-brain barrier permeability. This promotes neuroinflammation. That can make inefficient signaling. So one of the key takeaways are, when it comes to dysglycemia, it has a huge impact on all types of mood disorders. Now listen, it doesn't really matter what you name the mood disorder. It doesn't matter if it's bipolar. It doesn't matter if it's general anxiety disorder. It doesn't matter if it's social phobia. It doesn't matter if it's PTSD. It doesn't matter if it's major depressive disorder. It doesn't matter. These neurochemical alterations have an influence in all these types of mood disorders. And this is why we don't have protocols for each type of mood disorder. That chart I gave you with all different mood disorders, we don't have a protocol for each one. We want to go after the mechanisms that make those limbic circuits efficient. Okay, so that's dysglycemia. So this is a big part of the physiological web of mood disorders. It promotes the stress response, promotes systemic inflammation. We'll talk about how it impacts the microbiome a little bit later and hormone imbalance a little bit later as we get into each of these topics, but there's interrelation between each of these. Now let's get into stress physiology. And stress is a big deal, as we all know. Now when we look at stress physiology, here you can see, first of all, the HPA axis, the hypothalamus pituitary adrenal axis. And in the hypothalamus pituitary adrenal axis, you can see here they put a lightning bolt here, like boom, stress is impacting the system. And then they have acetylcholine, serotonin, norepinephrine, GABA, and interleukin-1, CRH, and they have pluses and negatives. So remember one of the concepts we talked about yesterday is the central integrative state. The central integrative state means the amount of excitatory inputs versus the amount of inhibitory inputs. You have more excitatory inputs than inhibition, you activate that pathway. You have more inhibitory pathways than excitatory, then the central negative state is inhibitory. And when you're looking at neurotransmitters, for example, they all have an impact on the HPA axis. So they all have some role to play in excitation, inhibition of cells in the hypothalamus, which are called the periventricular nuclear cells, the parvocellular periventricular nuclear cells. They activate this hypothalamus pituitary adrenal axis. And this hypothalamus pituitary adrenal axis is going to then release corticotropic releasing hormone. It's going to stimulate the pituitary to release ACTH, and then also known as corticotropin, and the adrenal gland is going to pump out cortisol, right? And this is the endocrine pathway. Now, when you look at cortisol and stress hormone release, you have to realize that chronic stress activates the cortisol pathway through the HPA axis, but epinephrine, norepinephrine, they're really activated by autonomics and midbrain activity. They're not part of that ACTH pathway directly. So there's projections from midbrain centers in the brain from the cingulum. So when you have stressful thoughts and activation of the amygdala and cingulum, they directly fire to midbrain reticulospinal tract, reticular formation, and rostral areas of the mesencephalon. And then they activate the sympathetic response, which then can cause changes in sympathetic responses. Now in a physical exam, when we get to physical exam, we really want to see, especially with our patients that have anxiety, are they in a full-blown sympathetic response? Do they have dilated pupils? Do they have reduced saliva production? So when we look at their mouth and shine a light in there, we should see a wet mouth. If their mouth is really dry, then we know they're not activating the parasympathetic. Their sympathetic tone may be too high. Increasing resting heart rate, fluctuation of resting heart rate, and just using a pulse ox, seeing what their heart rate is really critical when you look at anxiety patients. Elevated blood pressure, and then reduced bowel activity, bowel auscultation. These are things that all occur when the sympathetic system is so high, it dampens parasympathetic activity.